Hello, my name's Annette, and I'm going to be talking about malaria. So, a brief overview of malaria is a life-threatening bloodborne disease that is transmitted to humans through the bites of infected female mosquitoes. It is not contagious. There are rare cases of malaria in the United States, but is mostly commonly found in Africa, Southern Asia, Central America, and South America. And fortunately, malaria is preventable and is also curable. Some of the common names of malaria is egg and marsh fever, the Roman fever, simple intermittent fever, the shakes, and the mime. And a cool fact is that the word malaria comes from medieval Italian phrase malaria, which means bad air, which is also part of the miasma theory, in which the idea that swamps gave off pestilential fumes that caused the malarial disease back in the day. So malaria does not actually come from a bacteria, and it doesn't come from a virus either. So you might be asking, where does it actually come from? And you might have guessed it. It comes from a parasite. And that parasite is called Plasmodium, which is a unicellular protozoan parasite that can infect humans and cause illness. Therefore, it is an endoparasite. It can perform anaerobic respiration and follow both sexual and asexual reproduction, in which the sexual phase takes place in mosquitoes while the asexual phase takes place in the host. And there's 156 Plasmodium species, but only 5 of them cause malaria. And here is a pictogram of how the Plasmodium looks like. So its taxonomy classification is that it's obviously part of the eukaryote domain and part of the protista kingdom, and it goes to its genus, which is Plasmodium, and then the 5 species that causes malaria are going to be P. falciparum, P. vivax, P. malariae, P. ovale, and P. knowlesi. So the most notable strains are going to be the P. falciparum, which is the deadliest malaria parasite and the most prevalent in Africa, as well as P. vivax. And although it is deadly if left untreated, it's only prevalent outside of the African region. And then the other strains are going to be P. malariae, P. ovale, and P. knowlesi. And P. knowlesi, what makes it different is that it's a parasite of old world monkeys that can cause human infections and deaths, particularly in Southeast Asia. So its pathogenesis is really simple. The infected Anopheles mosquito bites a human, injecting sporocytes into the bloodstream. Those sporocytes travel to the liver and invade the liver cells, and then they undergo asexual reproduction producing merocytes. And then those merocytes can have an incubation period of up to 14 days or even longer, depending on the type of parasite the mosquito infected the healthy host with. And then those merocytes are released from the liver, and then they start invading red blood cells. And then they continue asexual reproduction inside those red blood cells. Then the red blood cells rupture, releases merocytes, in which they infect more red blood cells, causing fevers and chills as the immune system responds to the parasite. The destruction of the infected red blood cells triggers the immune system, which then pro-inflammatory cytokines are released, and then that basically leads to the host experiencing the severe symptoms. If malaria is left untreated, the infection can cause cerebral malaria, severe anemia, organ failure, and acidosis. And even then, some parasites form gametocytes that are taken up by the mosquito, continuing the cycle. So this is the diagram of what I just basically went over, in which the mosquito with the parasite bites the healthy host, and then the sporocytes travel through the blood vessel and enter the liver, and then those sporocytes enter the liver cells, and then they begin producing asexually, and then the liver cells rupture and merocytes are released, and then they go into the incubation period, in which then they go to the bloodstream. And then if this mosquito feels like having a blood meal from the infected host, they can actually get the gametocytes and begin and those gametes begin to fuse and the oocytes develops, in which then the sporocytes are released and they travel to two salivary glands through hyomocoeli, in which then they basically carry the parasite and they can begin infecting another healthy host. So how does the immune respond to all of this? First, the antibodies block the invasion of sporocytes into the liver cells. Then the IFNY and CD8 T cells inhibit parasite development in hepatocytes. Then the antibodies block invasion of merocytes into RBC. Then they prevent sequestration of infected RBC by preventing the binding to the adhesion of molecules on the vascular endothelium. The IFNY and CD4 plus T cells activate macrophages to phagocytose intra-RBC parasites and free merocytes. Those antibodies neutralize parasites and they inhibit the induction of the inflammatory cytokine cascade, in which the antibodies mediate complement-mediated cytolysis of extracellular gametes and prevent fertilization of gametes and the development of those zygotes. So, a brief history of the Malarian disease. The first written record of malaria in a Chinese document dates all the way back to 2700 BC. In 1880, Charles Louis Alphonse Laveran discovers the parasite in Algeria. In 1897, Sir Ronald Ross discovers that mosquitoes actually transmit malaria. And in 1934, Hans Andersog discovers the first anti-malarial drug in Germany. Then in 1952, malaria is eliminated in the United States. 1989, the US FDA approves the use of the anti-malarial drug. And in 1992, malaria vaccine candidate RTS-S enters in clinical trials and then becomes approved. And then lastly, present day, public health officials meet annually in New York and lay out a vision to reduce malaria cases, especially those in high-risk areas. So a little fun fact, Christopher Columbus suffered from malaria. Shakespeare actually mentions malaria in 8 of his 8 plays. And since we are UD scholars, we obviously need to know this fact. Dante died from malaria. A bigger yikes. Anyways, on to the next. So nearly half the world's population live in area at risk of malaria. In 2022, malaria caused approximately 249 million clinical episodes and 600,000 deaths. And approximately 95% of deaths in 2022 were in the WHO African region. And as you can see, the parasite is mostly prevalent in tropical areas, especially in Africa. So the transmission, as mentioned, it comes from the bite of an infected mosquito, but also blood transfusion from an infected human or contaminated needle can cause you malaria. Some symptoms of people who experience malaria, who have the malarian disease, experience high fever, chills, headaches, sweats, extreme fatigue, nausea, vomiting, and body aches. So kind of similar to flu-like symptoms. So some diagnosis is that first they do a blood smear microscopy to determine whether you have the malarian disease or not. Then they do either a rapid diagnostic test or a molecular detection, which is the PCR, and they use those tests to determine which type of parasite malaria you have in your system. And then obviously the treatment depends on the type of parasite, the severity of symptoms, your age, and whether you're pregnant or not. And then some of the common treatment are going to be the anti-malarial drugs, and then the artemisinin therapy, which is just simply the combination of those anti-malarial drugs. So who's at risk? It's children, obviously those who are 5 years or younger, pregnant women, the non-immune travelers, and people with compromised immune system, those with HIV or AIDS, and then surprisingly, those with blood types A or AB. So to prevent having malaria, first off, don't travel to places in which it's mostly prevalent. But if you were to travel to those places, apply mosquito repellent with DEET, put screens on windows and doors, treat clothing, tents, and other fabrics with permethrin, which is basically a mosquito repellent. And then if you were just to go travel for a couple of days, just take anti-malarial drugs, so that we could build up that immunity before going into that area. And there are actually vaccines. 2 malaria vaccines are recommended for children living in moderate to high malaria transmission areas, which is the RTS-S and R21. And those vaccines, they reduce malaria by approximately 40%. And they reduce severe malaria by approximately 30%, and then its mortality by 13%. And then fortunately for us, in the technological advancements, more vaccines are being developed so that way they could get approved, and not only on those cases with high malaria transmission areas, but also across globally. So some research contributions: that NIAID is conducting research to develop vaccines that target different stages of the parasite's life cycle. The CDC is also researching on new technologies for malaria control, and the USAID is conducting research to develop new insecticides and treatments for malaria. And some future outlooks: climate change also plays a big role in this, because just an increase of 2 to 3 degrees Celsius increases the risk by 5% of the area contracting malaria. So by us controlling the climate change can actually reduce the risk of people getting malaria. And then there's also new technological advances. There, like I mentioned, public health officials are creating new vector control approaches. They're developing new vaccines. They're trying different treatments so that way we could reduce the number of cases of malaria. And then those public health officials are looking for strategies in which to meet their goal, which is to reduce deaths by at least 90% by 2030, which is 6 years, actually 5 years from now, and to have it eradicated by 2060. So yeah, that's my works cited. Thank you for listening.